So I'll be sharing the quantitative indicator results at baseline, so where the focus populations are at for each of the leading projects prior to implementation. We anonymize the results, so you won't be able to identify the leading project, but it's really just to share how we're evaluating and sharing back this information with each of the teams. So individuals were included in this baseline if they were enrolled in home care and received home care services in the fiscal year of 2022-23. And specific program criteria were applied to the definitions for the baseline comparator populations. So some leading projects selected based on geography, whether the patients were palliative or not, their affiliation with primary care teams, or other criteria. And with respect to the palliative care populations, these were included or excluded based on a comprehensive definition, which extended beyond home care, as these programs are expected to expand beyond expand the home care-based palliative care to new patient populations. So here we have the list of the agreed to quantitative indicators. So the cross-project indicators were agreed to by all leading projects as core measures, which are applicable to all the programs. And these were selected in an open discussion with transparent selection and voting on indicators. We also have 4 indicators specific to palliative programs as well. So again, we're following the quintuple aim framework to evaluate these programs. And the quantitative piece of this work looks at some of the measures of patient health outcomes, the health system utilization, as well as costs. And we will also show some of the process-oriented measures that inform our understanding of what these programs are actually implementing. In terms of who is included in this baseline, the majority of clients are older, so the average age is 76, with 25% being over the age of 86. Most clients are female, and the largest proportion are living in neighborhoods with low access to material resources. So in this presentation, where I refer to material resources, this is the new name of the dimension of the Ontario Marginalization Index, which was previously called material deprivation. So you may be more familiar with that. So this is an area-based measure where people in quintile 1 would be living in areas with the most access to material resources, and those in Q5 would be living in areas with the least access to material resources, so the highest material deprivation. And here we can see that there's a tendency towards low SES or high material deprivation. So here we have the program activity measures, so service time per client month, as well as the proportion of service volume by type. Each of the bars on the graphs represents a different leading project. And I'll just say that when we're evaluating, we're not necessarily comparing between the different projects because they do have different objectives and populations, but we're presenting it this way just to show that there is variation in the projects. So here, this really does show the variation in services as well as the proportion by different service groups. And these are just informational items without specific targets at this moment. And they can help contextualize the results of some of the other indicators we have, such as cost. This is the caregiver distress indicator, and it's a measure of caregiver experience. And this data is pulled from the RAI assessment data, but we also have other survey measures of client and caregiver experience. And we also have later in the presentation, patient measure of care and how easy it is to access care as an important patient experience measure. So we can see that the caregiver distress across projects varies from a lot of distress, so 37, or far too high rates of caregiver distress, so 76% of clients who report that their primary caregiver experienced distress. We also looked at caregiver distress through an equity lens, and here we can see differences across sex. So this is actually the sex of the client and not the caregiver. So caregivers of male clients are more commonly reporting distress. And we also see differences across access to material resources, but in this context, it actually doesn't indicate inequity because we can see that areas with higher access to material resources are the ones reporting distress more frequently. And this could be due to several factors. I will point out again that it's an area-based measure, so it may not reflect the individuals living in the area accurately. And at this point, we also have not standardized these results. So just to interpret with caution. The next indicator is the wait time from referral to service. So this is an indicator of access or experience with care. There is a fair bit of variability across programs in terms of wait time length, but most fall within that 10 to 15-day range. But this is one of the measures that we are hoping to see some improvement on post-implementation for the projects. It's also another measure that we looked at through an equity lens. And in this case, we see again some differences by sex, but in this case, not by material resources. Change in health status, this is an outcome measure. And we saw that over time, the health status of long stay home care clients declined. And we're hoping that with the programs, they are able to slow the functional decline of clients over time. So this baseline measure will help us evaluate whether that is going to take place. So ED visits for conditions best managed elsewhere, as well as unplanned hospitalizations. These are both utilization measures, but also proxy measures for access to care and health outcomes. And again, we do see variation in these indicators across the leading projects. And these are also two indicators which we took an equity approach to. So again, for ED visits, conditions best managed elsewhere, we saw that difference in the sex of the client, but we did not see a difference in access to material resources. And this was also the case for unplanned hospitalizations. So as I mentioned before, there are also 4 measures which were specific to the palliative programs. So the first 2, which are ED visits in the last 30 days of life and the palliative home care visits in the last 90 days of life, these relate to access and outcomes. So the thought is that by providing more home care to clients in the last 90 days of life, the programs will be able to reduce the use of the ED in the last 30 days of life, as well as reduce overall utilization in the last 180 days of life. So if we go to the next slide, we can see that measure. So we're hoping that to improve on the amount of time spent at home in the last 6 months of life, and also hoping that clients will be more likely to die in the location of their choice and less likely to die in a hospital. So deaths in hospital is that proxy for death in location of choice. So lastly, we have costs, and this is an essential element of the quintuple aim. So here we are reporting on the monthly spending per client broken down by home care costs and other health system costs. And we will be keeping a record or reporting on this on a lagged quarterly basis. And this is another indicator where you see that variation by program, and more specifically, we see higher costs in programs where there are more hospitalizations. So that's it for the quantitative indicator piece.